I think I will start. So it's a great pleasure. So good evening in the morning or late middle of the night for some of you. So you get confused. And we know that from Australia is already middle of the night. For some it's the morning, and for us it's evening in Switzerland. So I'm Professor Didier Hunt from the Interdisciplinary Center of Bone Disease from the CHUV, Lausanne, Switzerland. And I'm currently the head of the research and development with specialty in bone health and body composition, as well as a fracture production model. And as we are, like many of us and you, I suppose that you're also developing a strong axis on applying AI to bone health. But let's be short here. I'm not here to talk about us today, not what we're doing with my. Let's talk about osteoporosis. So osteoporosis, it was the osteoporosis day yesterday. And osteoporosis is not just a matter of one day per year, obviously. But with this World Osteoporosis Day, it was a great opportunity to remind each of us how osteoporosis is important. And maybe take this opportunity also to refine our thinking for the benefit of our patients. So today it's my great honor to introduce you two persons from which I have extremely high respect and admiration, have to tell. It's Professor Bill Leslie from Manitoba, Canada, and Neil Binkley from Madison, Wisconsin. So all three of us have been past president of ISCD and are currently member of the Committee of Scientific Advisor of IOF. So I know them quite well and for many years. And because of that, I can say a few things about them. And so Bill and Neil are not only smart people with a huge level of experience, but they are both visionary and with their feet on the ground, because it's nice to have the vision, but if you lose the practical aspect, then you unmarch. And we have other industrial that can do that for us. But this is moreover, they have both an extreme high level of integrity and their egos have been far aside in everything they're doing. And that's very important, especially in nowadays, because see that at the end, we're not talking about ourselves, we're talking about improving our patient health and management of the disease. So that's very, very important. Well, I have to tell you also that, it's not clearly and not easy to convince them. And they are not afraid to tell you the truth, whether or not you like it or not. They will be pretty blunt in what they have to say. So don't get me wrong. I'm not saying that they are very stubborn. Actually, they're not, maybe a little, not too much. They just need facts and all rational behind any idea, concept that make clinical and practical sense. And when they have that sense, then they will not only talk, they will also act. And that's, again, very important. It's not like our politicians, they're talking a lot, but don't act a lot. So that's very good for all of us and so on. So I'm very lucky to know both of them and for so long, and I'm still appreciating them on a daily basis or virtually even, so I say, and that's a great pleasure. So having said that, Bill will start with a talk on artificial intelligence, commonly called AI, and in osteoporosis to demystify it for us. And Neil will elaborate around the vision of short-term evolution of DXA, mostly focused on bone health aspect. So having said that, Bill, it's your turn. So I will let you share your screen and you're on the stage for the presentation. So we'll have the two presentations in a row, and then we'll have like 10-15 minutes left for Q&A. So please use the Q&A chat room. There is a Q&A option here where you can use to ask the question, and then we'll moderate that after the talk. So Bill, all yours.
Well, thank you very much for the kind introduction and for not making it into a roast, because you do know me quite well. I assume you've got my first slide up on the screen there.
Yeah, we do.
And this is going to be a journey. The journey is not over. I think the AI journey in osteoporosis is just beginning. But I want to share with you some learnings along the way and get you prepared for what is going to be revolutionary in healthcare. My disclosures are here. I have no industry disclosures, but I do have collaborations with Didier and others around FRAX and TBS and a number of contributions to different organizations. To say that AI is hot is an understatement. This is a graph of the AI or machine learning publications that you can get off of PubMed since 1990, and you can see that this went from virtually zero to over 10,000 in the last year, with a total of almost 40,000. So this is an explosive field, and the osteoporosis angle is still new. Up to the present time, quick search, about 63 papers, again, almost all in the last few years. But you can see that the trajectory on this is definitely taking us towards this exploding into all aspects of healthcare. Now, I've been on the AI journey, I'll tell you, since about 1970. I was a computer geek before the term existed. And I've seen it come and go. We've actually had 3 booms and 2 busts in the history of artificial intelligence. Initially, the hope was that we could create a checkers program, and the next step from solving checkers was Skynet and computers taking over the planet. Didn't happen. That was the first AI winter, so-called. Next, that computers could be taught to do very focused tasks, antibiotic recommendations, so-called expert systems. That was really popular in the early 70s and to the early 80s, but the bottom fell out on that, and we went into the second AI winter. So what we're seeing now in terms of AI is really the third boom, and this is the machine learning boom. So far, this looks like we don't have a bust in the horizon. It's still continuing to grow, and I think this one here is actually going to stick. Thanks to people like Geoffrey Hinton at the University of Toronto, who didn't give up during the AI winter. He continued to labor through the long, hard nights, developing algorithms and the computing expertise that is now made artificial intelligence and machine learning work accessible to the masses, so that you can go online and find introductions to deep learning, machine learning, using off-the-shelf textbooks, off-the-shelf software, and very inexpensive hardware to do things that were unimaginable even 10 or 15 years ago. So I'm going to start this. I know I can't get a show of hands, but in your offices, you can say, how many of you are actually routinely using AI machine learning methods in your day-to-day practice or life? And the answer is, you actually all are, because machine learning and artificial intelligence methods are sort of like genetically modified foods. We no longer have a choice about these. They're in everything. They're in your smartphones. Every time you do a Google search, you're using this. If you speak to Alexa, you're using this. All of the voice recognition systems are all machine learning methods. And so this is really becoming widely disseminated in technologies, many technologies that you don't even recognize as having advanced AI methods. This is an article I found just today. It was published in the Nature series in beginning of September, and identified that up to the present time, 64 AI and machine learning methods have actually been FDA approved. So these are in your devices and algorithms that people are using, and they probably don't even know it, because only a minority of these, even in the official FDA announcement, pointed out that these actually had AI or machine learning embedded in the methods. If you're interested, there's actually a link where they promise to keep this up to date, where you can see where all of these FDA-approved AI algorithms will be listed. I didn't see any for osteoporosis as of today. A fairly standard introduction to AI looks at this hierarchy, where artificial intelligence is a very, very broad area. I don't think any of us think that machines think, but it's the broadest concept of getting computers to behave intelligently. A specific subgroup of that uses training methods to sequentially improve the performance of machines so they can do difficult tasks, so that they essentially learn in a method somewhat analogous to how people learn. And then there's a subgroup within that, deep learning methods, which I'll be illustrating in my talk. Typically, these machine learning algorithms are subgrouped as supervised, unsupervised, semi-supervised, which is halfway in between, or reinforcement algorithms. The vast majority of the research is currently taking place with supervised methods, and that's what I'll be speaking with. And that's where you basically have input data. You assign a label to the input data, disease present or absent, or some other variable that you want the machine to learn how to predict. And then the machine learning model attempts to find a relationship between the input and the output label, and to approximate that as well as possible in the training phase, and ultimately, of course, to be able to apply that to cases that it hasn't seen, so that it is useful for future case prediction. It's worthwhile to compare the classical statistical methods to machine learning methods, which is really just an extension of classical statistics, but it's of a high dimensional sort. And I'll explain what I mean by that a little bit later. But in your standard classical statistics, we're used to using multiple linear regression or ANCOVA or GEE, any of these standard methods, or you can use Cox regression or logistic regression to predict time to event or dichotomous outcomes. Machine learning has similar but much more flexible methods that can achieve these same sorts of tasks. The support vector machines, random forest, extreme gradient boosting, convolutional neural networks. There's a whole host of different methods that are being developed, but suffice it to say that these do have broad applicability to the range of classification and prediction problems that have been addressed by classical statistics. We actually have been playing around with this, and we have developed programs around abdominal uric calcium scoring automatically, enhanced fracture prediction, currently we're calling it superfracs, or vertebral fracture prediction off of DEXA images. And these techniques, I should point out, are remarkably flexible, because we're using techniques that are the same as are used to classify cats and dogs on Google Images. This is Fifi Liu giving a TED talk, and the methods that she talked about for general images work perfectly well for medical images. And so one of the things about the machine learning area is its incredible flexibility. At the core of the deep learning method is this node or neuron, artificial neuron. And you can imagine that you have a series of inputs to this, series of weights. You do some simple arithmetic to sum up the inputs times the weights with a bias measure. And then that feeds forward as an output value. That value then triggers the next downstream effect to either activate or not activate, depending upon some sort of a thresholding algorithm, and leads to an output. Now that's one neuron, but of course these neural networks that are being constructed are comprised of thousands or many thousands of neurons. And so you have layers of these feeding forward their predictions from as a cascade, one to the next, and they feed forward all the way to the end, where you get an output which is supposed to predict cat versus dog. If you get it right, pat on the back. If you get it wrong, you measure how far you were from the prediction, and you feed that error backwards through a backwards propagation algorithm that goes backwards through the algorithm. You adjust all the weights again so that the next time you don't make the same error. Now, of course, This has to be done many, many times and uses a very large training data set. Ideally, cases in the thousands, if not millions of cases, but in medical practice, we typically are more in the thousands of range. And this is basically at the heart of supervised deep learning. A convolutional neural network, or CNN, is a widely used approach in artificial intelligence, and basically it uses at its core a convolution filter, which is applied. Imagine this is an image. You take the filter, you apply it to each segment of this image, you do some simple matrix arithmetic, and put that into the new image. So you construct a new image which has been filtered using this filter from the original image. And again, it's easier to show that with a simple example. You could have an input image, apply the convolution filter, and might have an output image which has some rough correspondence to the initial image. But again, you can do this not once, but many, many times with many different types of filters in order to enhance different aspects of the image. It's called deep learning because you take from your image to your output layer after layer after layer. Sometimes a few layers, sometimes dozens, potentially hundreds of layers can be interposed between the input and the final output. So in this example, where you're trying to teach a machine to identify handwritten digits, for example, for a postal code recognition, you can see that there are many, many different types of layers that can be stacked together and connected to achieve this, this task. Now, I'm going to talk specifically about the convolutional neural network and our experience with vertebral fracture identification, because I think this is illustrative of the strengths and weaknesses of these techniques. I'm speaking to an osteoporosis audience, and I'm going to assume I don't have to sell you on the importance of vertebral fracture identification. In most algorithms around the world, you identify an incident vertebral fracture, and that's generally a marker of clinical osteoporosis and somebody that needs treatment. So it's important to identify these. But there's a lot of variability in the quality of recognition of vertebral fractures. You can see this chest X-ray that was reported as showing multiple minimal compression fractures. When I see multiple minimal compression, I immediately am wary that this may be a false positive. This individual subsequently had VFA and CT. There are no vertebral fractures, so we have a false positive on this particular report. At the same time, we know that there are lots of false negatives. This is a VFA we did, no difficulty identifying the fracture. But if you go back, you can see that this fracture has been present on previous CT and chest X-ray, which was sequentially missed on all of these. And so there is clearly a problem both in sensitivity and specificity of vertebral fracture recognition in routine practice. At the same time, there are a lot of non-fracture variants. And if you're going to be reading a vertebral fracture assessment, you have to be familiar with these. Congenital deformities like the butterfly vertebra or the Cupid's bow, or acquired deformities like the mother of all Schmorl's nodes here in the superior end plate, which are not true fractures. So we really do have a perfect storm for vertebral fracture diagnosis. I promised some storm pictures. This is what things looked like this morning when I woke up to our dump of snow. And this is last year when we got an extra big dump of snow. And in fact, it brought down thousands of trees in our city. So I'm familiar with storms. And vertebral fractures are no exception. We recognize that their importance. They produce few symptoms. Imaging generates false negatives and positives, and sometimes even the experts disagree about what isn't or isn't a vertebral fracture. And of course, what's the hope for non-experts who are trying to get into this and perform vertebral fracture assessment? So we ask the question, can computers do better? And based upon what I've shown you already, you could say, well, they can't do much worse than what already happens in routine practice. But imagine if you had Harry Janant on speed dial on your phone, and you could call him whenever you got into trouble with a vertebral anomaly. Or better yet, let's say we could clone Harry and put him around the planet in thousands, if not millions of locations, and he would be there watching over your shoulder, giving you advice on what is and isn't a vertebral fracture as you're going through your daily practice. That's essentially the promise of machine learning. This is the stereotypical machine learning workflow. You start with data collection, data preparation, and then you get into algorithm selection, training, evaluation, prediction. Data collection, data preparation is actually about 90% of the work. 10% of the work is actually the machine learning part. Most of the work is actually at the front end in terms of data acquisition and labeling. So our experience is going to be with the use of vertebral fracture assessment, which we've been performing for about 10 years. There are the criteria that we use, which are fairly standard criteria for who should or shouldn't get a VFA in our practice. At the end of the day, in our reporting, we score these as yes, no, or maybe. We try to avoid the maybes, but yes or no for the presence or absence of vertebral fracture. We did not record where the fracture was, only the presence or absence, which is important because you're asking the computer to learn where for vertebral fractures without really giving it localization information. We use the algorithm-based qualitative method to score these, and we did a lot of PACS review to confirm vertebral fractures and make sure we weren't overcalling or undercalling in the course of our work. And as necessary, we consulted with experts. We're not ashamed to seek outside advice. So in the data set that we use for the training, we had almost 13,400 scans. Very few of them were excluded. And we divided those scans into the ones that we'll use for the machine training, 10% held out for validation, and then 30% as a totally independent test set, so the computer doesn't get a chance to look at these when it's in its training phase. So over 10,000 for the overall procedure, which is reasonable for machine learning. You have to deal with a lot of upfront data processing problems. We had two different generations of scanners, lower resolution, higher resolution. So we had to rescale those to meet somewhere in the middle. We had to deal with the fact that our patients are from the real world. So some of them come in with different kinds of artifacts, orthopedic implants, they're wearing stuff. Do we exclude these? The answer is no, we leave them all in the mix. The human has to read these kinds of scans, so the machine, if it's going to be helpful, has to learn how to read these kinds of scans and ignore the extraneous junk that makes our work as clinicians difficult. We also don't want the machine to simply memorize which cases are positive or negative. We want it to truly learn the features that are important, so we try to throw it off balance. We augment these data sets by flipping them, rotating them, stretching them, doing as much so that each time it sees the same scan, it's never quite the same. So as much variation as possible to avoid memorization of specific patterns, so it truly learns how to what's called generalize to unseen cases. So this is are the models that we trained. I won't get into the details on their construction, but I will highlight the numbers of layers. So hundreds in this one, 44 in this one. The numbers of parameters that we're fitting are not in the tens or hundreds or thousands, but we're actually fitting in the millions of parameters. So this blows the top off of conventional statistics, where you typically want to have 10 to 20 events per variable in your model. Clearly, these are extreme overfitting problems, and something we have to guard against, which is why we have the separation of training, validation, and test data sets. I'll skip to the bottom line. At the end of the work, using the two different training algorithms, the DenseNet and the Inception Rest, or taking the maximum of these, you can see that to classify vertebral fractures as present versus absent compared with a human pseudo-expert, it achieves an area under the curve of about 94%. And that's probably about as good as any human expert could get, because no two humans will be 100% in agreement about presence or absence of vertebral fracture. So the fact that the computer is up at that level was actually quite a surprise to me. The acid test, though, is what the computer is identifying as a vertebral fracture predictive of outcomes. So we were actually able to take almost 3,000 of these individuals and follow them forward in time to see who actually sustained non-vertebral fractures or hip fractures. And this shows the separation of the curves in the VFA negative versus the VFA positive. The black versus the gray is the human versus the computer prediction of what is a positive, and you can see that they largely superimpose, so that what a human identifies as a vertebral fracture and is predictive of hard outcomes works as well with the machine identified vertebral fracture. What is the machine actually seeing, if we can use that anthropomorphism? Well, you can use what are called heat maps. These basically identify the pixels in the image that are contributing to the final output. So you can see in this example of a single vertebral fracture here that most of the heat is in the area of the fracture. In an individual who has multiple fractures, you can see again heat and warmth as it localizes to the presence of these fractures. And so this field of visualization of machine learning is still early on, but this is a very common method that's used. The holy grail is, of course, to take a machine who has learned how to identify vertebral fractures off VFA and be able to apply that to chest x-rays, CT scans, MR, and everything. That is easier said than done. And I'll show you the reason for that. I'll also point out that vertebral fracture identification is actually coming to a PACS near you if you haven't actually already played around with this. Zebra Vision actually has commercialized AI methods, and they have been promoting a method that they have trained to identify vertebral fractures off of CT scans. In their initial data set, this achieved very respectable sensitivity and specificity. Accuracy is almost 90%. But be wary, whenever you test in a new data set, you expect some loss in performance. And so a recent publication from Australia found that, in fact, sensitivity in an independent data set for grade 2-3 genet fractures did fall to about 65%, but maintained specificity at the same high level. So are we ready for prime time with our algorithm? And I would say not yet. We've actually only tested so far on the GE method. We have not validated this for other scanners, such as the Hologic design, and these are quite different. You can see a dual energy versus a single energy VFA look very different. A human can easily learn to extrapolate from what is a vertebral fracture in this to this, but how well will a computer learn to extrapolate that? Can the computer actually transfer what it learns from one format to the other? Well, we recently looked at this. We identified that if we looked at the single energy GE versus the dual energy GE, that both of them give you very high performance, AUCs greater than 0.9, when they're tested and trained on the same type of data set. If you cross over to the opposite, unlike a human, the algorithms do not generalize. The AUCs are almost non-existent when you ask it to train off of one type and evaluate on the different type. Our student had the great idea, though, of trying to improve the generalization by throwing everything into one pot. So basically, you create a composite and ask it to learn off of single energy, dual energy simultaneously. Don't tell them which is which, and see how that performs. And the answer is, it actually learns how to separate out the single and the dual, and learn all at the same time with an AUC that's 0.94, equally good across both types of algorithms without being told. So we're seeing this kind of sequential composite training as maybe a bridge to be able to go from GE to Hologic, but that's a work in progress. I'm going to wind up now and just say that if I've whetted your appetite, please feel free to go back to the ASBMR Plenary Symposium on AI and Precision Medicine, which had a number of superb speakers on machine learning methods. You can see some well-known folks, including John Shepard, another past president from ISCD. So we're very inbred in our field, of course. I would also point out that JAMA has had some superb articles on use of machine learning, and also has one on how to read a machine learning article and evaluate the literature. And I'll quickly give you the bottom line. Use your clinical judgment. Clinical gestalt plays a crucial role in evaluating whether results are believable. If it sounds too good to be true, it probably is. So with that, I'll conclude and say I'm truly a converted skeptic on my journey with machine learning, but be wary, be a wary consumer. Independent validation of all of these algorithms is very important, and more important even than conventional medical prediction tools. Machine learning is here to stay, and it not just will change, but actually is changing and has changed the practice of medicine. So with that, I'll acknowledge a number of people, but tell you that I'm always open to collaboration. So if you have a large data set, especially with vertebral fractures, your name goes here, looking to hear from you. Thank you very much.
Thank you very much, Bill, for this enlightening AI. So it just clearly confirmed that you're a smart person. So we'll save the question for the end, and I will ask Neil just to share his presentation and unmute and share the presentation, and we go straight with a few application for DX and TBS from Neil. So Neil, it's all yours.
Okay, thank you, Didier. I will be discussing the future applications of DEXA and TBS. My disclosures are, as you see here, that some of this is my opinion, and you'll see a fair amount of that. And I denote that shorthand by the orange text color. Much of what I'm going to discuss today is directly related to orthopedic surgery. And I should disclose that I am not an orthopedic surgeon, but I am working very closely with my orthopedic colleagues and with our local fracture liaison service that lives under the umbrella of orthopedics. So my opinion is that the most recent substantial advance in DEXA is the trabecular bone score. And you're all familiar with TBS. I'm not going to review it in any detail. You know, it's a software program that estimates bone texture from currently a regular PA spine DEXA. It is a surrogate of bone microarchitecture. We do not have the spatial resolution to see microfracture or microarchitecture on a DEXA scan, but it is associated with microarchitecture and with fracture risk, and it is additive independently to BMD and clinical risk factors. It's my bias that the next major advances in DEXA and TBS will be related to orthopedic surgery. So this is a slide that I borrowed from a friend of mine, Paul Anderson, who is a spine surgeon, and asking the question, why should orthopedic surgeons care? And the answers are, as you see here, it's common, it's associated with fractures, intraoperative complications, bad outcomes, increased need for revision surgery, correction or treatment of the osteoporosis mitigates these negative effects. And as Paul in his usual way says, nobody else is managing it. And everyone on this call, I'm sure, is familiar with the so-called treatment gap or osteoporosis crisis. We as clinicians need to be doing a better job. Now, how does this relate to orthopedics? Well, total joint replacement is incredibly common worldwide, and it's generally increasing in numbers. Here's some data from the Organization for Economic Cooperation and Development. And as you see here, in a variety of countries, the number of total knees is going up, the number of total hip replacements is going up, in no small part due to the aging of our population. And indeed, when we consider that in the United States, 1 out of 8 Americans over age 70 has had a total knee arthroplasty. And these are very successful surgeries and contribute to quality of life of older adults. But periprosthetic fractures, fractures that occur around or near the prostheses, are incredibly common, and in my opinion, should be considered osteoporosis-related fractures. These occur in roughly 1 out of 20 people who've had a total knee arthroplasty. They are so-called low trauma, generally due to falls. Additionally, roughly 3 out of 4 people who get a total knee have low bone mineral density prior to getting their total knee replacement. And when we put in a prosthesis, we cause regional, i.e. distal femur bone loss of roughly 15%. There are a multitude of potential mechanisms that cause that. But here is a meta-analysis that is out there speaking to the loss of bone following a TKA. And it's somewhere above 15% locally, that appears to generally plateau about a year after we have put in this prosthesis. Now, we do not have a T-score approach at the distal femur, but 15% would be roughly 1.5 T-scores. And so if you start with low BMD and you lose another 15%, guess what? You're low. And it looks like this does not recover. Now, it is important to emphasize that we as the DEXA field have not standardized these distal femur ROIs, but it's my bias that this almost certainly has to contribute to an increased periprosthetic fracture risk. And these fractures are ugly. I'm really impressed with my orthopedic colleagues that they're able to put Humpty Dumpty back together again. When you look at these fractures, you just sort of scratch your head and say, how do we put this back together? This is a fracture that is technically challenging to repair and has major personal consequence. And in essence, periprosthetic femur fractures should be viewed by those of us in the osteoporosis field as being the same as the classical hip fracture. And I'm not going to go through the data. This is just 2 approaches to fixing the problem, but the punchline is right here. The 1-year mortality is 20%. The effect on mobility is only half of people regain their prior mobility. That's what all of us are used to hearing in regards to classical hip fractures. These periprosthetic fractures are bad, and we need to be doing something about them. Now, we don't have fracture data yet that says we can prevent this, but what we have implies that we probably can. Clearly, bone loss after total knees can be mitigated by medications documented for bisphosphonates and teriparatide. Osteoporosis is associated with subsidence around the implants, which is a common cause of need for revision surgery. There is a meta-analysis out there that finds that bisphosphonates following total hip and total knee reduces revision surgery by over 15%. So we do not have the classic osteoporosis trials of 5 or 10,000 patients, but common sense would say, supported by the existing data, that we as osteoporosis providers can do something about this. And there are other complications of osteoporosis: reduced pullout and insertional torque strength, screw loosening, post-operative fracture, and the lower the bone density, the lower the screw torque, and the lower the screw pullout strength. It should matter. And so in summary, osteoporosis is common preoperatively surgery causes bone loss, low BMDs associated with adverse outcomes. We got to be measuring it, right? Well, here's a survey of over 400 orthopedic surgeons. And the question was, if your patient has osteoporosis, does this influence you on what you're going to do? And the majority said yes. Well then, do you regularly measure bone mineral density? 95% say no. And this was replicated in the States. Basically the same questions. Does this influence you? 80% say yes. Do you measure? 90% say no. This needs to change, and I believe it is changing. And as part of that, these are the recent ISCD official positions relevant to bone health optimization. And you can read this as well as I can read it to you, but it basically says that if you're doing an elective orthopedic procedure, you should be doing bone density testing, and if you have diabetes, that should include TBS. And so inflammatory arthritis, steroids, low trauma fracture, CKD, etc. Now, we can and we need to be performing distal femur BMD measurement. And what this shows you is that you don't get all of the information just by looking at a proximal femur DEXA. In this study, we utilized the AFF software to allow us to image the whole femur, arbitrarily placed regions of interest at 15 and 25% above a total knee, and compared it to the contralateral side. And what this demonstrates, unsurprisingly, is that there is a substantial difference between the operated and non-operated side, and that we don't pick all of that up just by measuring the total proximal femur. This approach is laborious. It is not yet available from the DEXA manufacturers, and as such, it's not yet standard of care. Moreover, we can measure volumetric, or we can measure cortical thickness. I misspoke. We can measure cortical thickness. And here we use the AFF software, and this is just looking at cortical thickness. And as you would guess, the cortex is thinner in the operated leg, both medially and laterally. Now, we're using software that's designed to look for AFF up in the more proximal femur, and we're pushing it to say, can you measure the cortex down here near the implant? And it generally did, but you can see here is an example where it just fell apart, both on the operated and non-operated side. So here's an obvious area where we need software and or hardware improvement to measure cortical thickness. We can also measure distal femur TBS. And here we could measure the whole distal femur, which would include the patella, obviously, or we can look at the regions of interest as we proposed. And here again, unsurprisingly, in the operated leg, this is TBS, we called it BTS for this abstract. In the surgical leg was lower at both the 15 and the 25% region of interest. And importantly, much like at the lumbar spine, the TBS appears to be independent of the bone mineral density, further implying utility of local measurement. So when we measure the distal femur, why aren't we including the proximal tibia? And why aren't we looking at TBS in the proximal tibia? Because we're getting implants put in there. We have not done that yet. It's an obvious next research step. Additionally, we can, and in my bias, need to measure BMD around total hip prostheses. This software is currently available. These are the so-called Gruen zones around a total hip implant. This is a patient of mine in whom the BMD at Gruen zone 1 was incredibly lower than everywhere else. We could not see evidence of osteolysis here on her radiograph, but she was having pain. And while I told her that I didn't know exactly what I was treating, I did put her on a bone anabolic, and her pain dramatically improved. This is something that we have currently available. We need to be using it and need to understand what to do with these data. Additionally, DEXA could be giving us the DOR classification. The DOR classification is, as you see up here, A, B, and C. And this is something that orthopedic surgeons commonly utilize as part of their pre-total hip arthroplasty preparation. Here's an example of obtaining this by DEXA, DOR A, B, or by X-ray rather, DOR A, B, and C. And here is a DEXA image of DOR A, DOR B, and DOR C. This could, and in my bias, should be automated by the DEXA manufacturers. When we obtain a proximal femur DEXA, why are we not getting an automated DOR classification? And in addition to that, we could be including TBS at the hip. And here, you're familiar with at the spine, you can have the same BMD, but different TBS, exactly the same thing shown here. Total femur BMD virtually identical, total TBS dramatically lower. And while this isn't a radiograph, this thick cortex here makes me wonder if this is a DOR A and this is a DOR C. So this is something that we obviously need to be bringing forward. Additionally, shoulder arthroplasty is being increasingly performed. Why are we not measuring bone density of the proximal humerus? We can. And here in some pilot data are DEXA images of arbitrary regions of interest of the proximal humerus with their corresponding trabecular bone score in the area where the surgeon is going to be placing the implant. Shouldn't that be important? We don't know yet, but we need to be doing this. And finally, spine surgery. Clearly, impaired bone health has multiple adverse consequences for spine surgeons. Non-union, loosening of screws, hardware failure, cage subsidence, proximal junction fracture and kyphosis, increased spondylolisthesis and scoliosis, increased need for revision surgery, pelvic and sacral and vertebral fractures. So we need to know about bone health when we're doing these big spine operations. Just one example of data. Here's osteoporosis related complications going up as the BMD goes down, non-union higher in people with osteoporosis. We can do TBS on VFA images, and it's logical that this knowledge that this patient's TBS is lower than this patient's might be beneficial to the surgeon. And indeed, in these data that Riley White reported at ISCD, in patients with fracture in the blue, the TBS laterally at L1 and L1 through 4 and L2 through 4 was lower in those with prior fracture. We don't know how exactly to do this here. And it may be that we should be measuring L2 through 4, possibly due to rib overlying L1. But the potential here, I think, is obvious. And finally, it's logical that bone be optimized prior to elective orthopedic surgical procedures. This is a nice review now from 2 years ago, where the surgeons are optimizing virtually everything that they can prior to these big operations. And this is the list. You see that bone is not on there. Why not optimize bone? And ISCD did address this, and there are now orthopedic positions related to BHO, and that basically says it should be considered and think about it. And additionally, for those of us who are not surgeons, when the surgeon comes out of the OR and said, hey, the bone quality is terrible, this was like putting screws into butter, we should believe them, and we should do a skeletal evaluation. And so measure BMD, VFA for patients having spine surgery. And this is a totally opinion-based approach that I just elected to share with you, is that the surgeon identifies an at-risk patient when they're scheduling or thinking about surgery. They are recommending routine vitamin D and calcium supplementation. They are performing a FRAX calculation without BMD. If it is, quote, high in the US, above 8.4% MOF, they get a DEXA. If the DEXA is normal, they go to the OR. If it's not normal, they get referred to a bone health specialist. We need data validating this approach, but at any rate, this is just a framework to think about. It seems certain to me that TBS knowledge of bone at the surgical site will be beneficial for pre and post-operative evaluation and care. It's intuitive that you don't want to be standing on the scaffolding. You don't want implants placed into this bone. And so in summary, in elective orthopedic patients, osteoporosis is common. Surgery causes bone loss. I didn't share with you the data about vitamin D, but low vitamin D status is very common in these folks. This likely contributes to adverse post-operative outcomes. We need something other than opinion and common sense, a huge research need. Who and how to screen, what's the appropriate evaluation, who to treat, and with what, and when you delay surgery, for how long. So my predictions and research needs for the near future of DEXA and TBS are as you see here. I believe that DEXA will become a routine part of skeletal assessment and optimization prior to elective arthroplasty and elective spine surgery. I think this will include TBS at sites relevant to the hardware placement. We need data that it alters surgical decisions and outcomes. We need DEXA ROI standardization and automation of these by the manufacturers. And as I noted, we need improved cortical width measurement capabilities. We need to clarify the role of localized TBS in surgical planning. Ask whether it predicts intraoperative or postoperative outcomes. And finally, we need to define low BMD and low TBS at each skeletal site. And what are the intervention thresholds for this low value? I suggest that rather than trying to go back and recreate the wheel with normative databases and in essence T-scores, that we may be able to simply correlate with spine or hip DEXA rather than totally reinventing the wheel. So in summary then, I think that what I view as the logical explosion of a relationship between the osteoporosis provider and the orthopedic surgeon, the integration of DEXA and TBS into this population is a really exciting time for our field. And I think it really is going to be a substantial step forward. And I thank you.
Thank you very much, Neil, for this vision of the future use of DEXA. Well, I would say not a long-term, but a fairly short-term or medium-term vision, because as you mentioned, there's already several ongoing studies, and we all know that when we start to study things, it's a machine of research and applications coming more and more people just get involved and so on. So that's clearly a path to go on the orthopedic side. So having said that, now it's time for bombard our two speakers with questions. So please use your Q&A to type it in, so it'd be just easier for us rather than authorizing, just to turn on the microphone and talk all in once, because there is a fair number of people connected, so that just can turn that into a nightmare. And I'm not quite sure that artificial intelligence will help us to select who should ask the question first. So be on a Q&A basis. So before going to, I will ask my first question so that it gives time for people to type in their questions. And actually, I will ask the question to both of you by starting asking the question to Neil and have Bill help me to understand that. So you talk about a lot of we should have something calculating the cortical thickness, or we should have software help us to do that. We also know that garbage out when we're using analyses, and sometimes analysis is not always been perfect. So do you think that AI, so machine learning, can help us is improving some of the DEXA outcome by automatizing some of the features that we used to do manually, or we're not been good in follow-up, for example, or like in detection, or many other things. So could it be a bridge between what you said, where a lot of future application could be, to my opinion, put by AI, but I will have the opinion of both of you on that.
Yeah, Didier, I think you're exactly right. I think that I think DEXA is just incredibly low-hanging fruit for AI and DEXA interpretation particularly. The regions of interest that I showed you, there is not yet a standard recommended by ISCD or anyone else, and that's obviously a need, but I think clearly AI could do that. And I think that the interpretation or the output of DEXA, as we all know worldwide, the quality of that is suboptimal. And I love Bill's slide that says, could computers do better? It's impossible for them to do worse than what we are doing. I saw a patient last week whose DEXA report, true story, said that this bone density is consistent with osteoporosis, osteopenia, or normal bone mineral density. What is the clinician supposed to do with that? I think it's certain that AI could be assisting us in our interpretations. And I'd like to hear what Bill has to say about that.
Well, we're all three of the same mind on this. That's the starting point. But getting back to Didier's point about what are we training the algorithms to do? Are they supposed to match humans? Or are they supposed to actually find novel features that we haven't thought of yet? And I think that's where the future is actually, is to go beyond simply trying to find better ways to measure bone density, or to pull out hip axis length, or even TBS as parameters that we've conceptualized. We have a framework for why we want to look at them. But I think DEXA has lots of information buried in it that we haven't come close to finding. And so my hope, and what's in our future plans, is to get away from trying to replicate human behavior, but to actually train off of the outcomes themselves, so that you can identify from a DEXA spine or DEXA hip the features that are predictive of the outcomes that you want to identify and avoid.
Yeah, I think it's right, but there is for me a two-layer of approach. First is just to optimize what we have right now today, just to make it very short term, make it our life easier. And then the second step that will go several steps further, that will still require some time for medical acceptance. And I say in one of the LinkedIn posts is the idea is not is not the purpose to replace the medical doctor or the clinician, but to help us to get better so that we can focus on all the tasks closer to the patient, something like that. But I fully agree with your approach, and I think many of us are already working toward that directions. And I can tell you that some of the features seem to be extremely encouraging for what we have seen on some pilot studies that we're also doing with a group. We have a question here, several questions. I think Bill and Neil, you can see those questions, correct?
Yes.
So the first one is from Lauren Jansky. And do you have any sense of whether bisphosphonates increase the odds of periprosthetic fracture due to the same mechanism that it increases atypical fracture?
Well, I'll take the first shot at that. You know, there's a nice review of atypical femur fractures. I think Dennis Black might be the lead author on that. And they concluded that we don't really know the pathophysiology of atypical femur fractures. Having said that, it makes sense to me that AFF is due to oversuppression of the bone remodeling process in a somehow susceptible patient as an individual. There are case reports out there of atypical periprosthetic fractures in people who have been treated with long-term bisphosphonates. And so if the mechanism is oversuppression, then it would make sense to me that you could have the same pathophysiology around, for example, a total hip prosthesis. I think that the practical consequence of that is that while the data are out there saying that bisphosphonates are good after we have had joint replacement procedures done, it probably doesn't mean that you should be on a bisphosphonate forever plus 1 day. And so I think that we should look at bisphosphonates if we're going to use them in the orthopedic world to improve outcomes after total joint arthroplasty. We should have the same limitations that we have in the classic osteoporosis world. That's my opinion.
All right, thanks. You want to add on that, or you're fine? Okay, we're fine. Someone asking you, Neil, if you can share your methodology for creating ROI on a EFF lunar scan, which scan mode you up for use and shoulder exam and so on.
Yep. That needs to be an offline.
Yeah.
And so if that person could reach out to the Heatmaps team and email me directly. The short answer is it's hard and laborious, but it can be done. And we are currently doing shoulder exams using Femur software. That's early in the game, but it looks like it does work. And I'll be happy to share that with you as well if you reach out to me personally.
Another question to you is, can you please elaborate what you mean with establishing the threshold with DEXA correlation femur versus traditional normative data approach?
Yep, and that is my belief that we should not make the perfect the enemy of the good. So I think that in a perfect world, if we would like to go back down the road of having a T-score based approach, we can have that discussion, but it will require some fermented beverages. If we wish to do that, that means we're going to have to get large normative databases at all of these non-typical skeletal sites. And, you know, to ask for that, I fear it simply isn't going to happen. But if we're going to have this, you know, orthopedic surgeons are going to say, okay, so what's good and what's bad? What's high and what's low? And you know, a logical approach would be to correlate that with our standard sites, where we know what a femoral neck T-score of -2.5 is.
Okay. Yep. Thank you. I will just just a quick one. I noted that while TBS is not affected as BMD by degenerative spine change, but it's still affected in some patients substantially. Do you agree?
Let me take that, Didier.
Go ahead.
Because you have this problem that you've got all this stuff about Heatmaps behind your name. You know, I agreed with that 100%, but a colleague of mine, I mentioned his name, Paul Anderson, he's a spine surgeon. He has data that we have not yet published where they looked at patients where we had TBS and where we had spine CT. They applied two really quite robust measures of spinal degeneration and concluded that the spine TBS is not affected by degenerative change. I don't know that that's true in every patient. And I sort of had the general gestalt of the person who asked this question that I see people where there's all this degenerative junk and it feels to me like that's affecting TBS. But Paul's data, not yet published, implies that maybe that is not the case. But I don't think it can be 100% in every patient. That's my bias.
You want to comment on that, Bill?
No.
I think I will agree. I've seen that also in a practice that in majority of the patient is not affected. We can see a large discrepancy with a BMD. In some cases, and especially when we start to have like a spine rotation and stuff like that, where it's not much related to the arthrosis, but BMD is a projection of the rotation that can just impact some result. But obviously, at one point, we're still applying to the ISCD rule to exclude some vertebrae, but it's good to know that in case it's not done, or in case of residual arthrosis, or just homogeneously spread around the spine, then we're not impacted, and that's really reassuring. So we have another question here, mostly for you, Bill. Given that all hospital RACE system have a diverse digital source from DXA, X-ray, CT, MRI, cath lab, etc., we're looking to have a single AI tool to track all vertebrae fracture and TBS to provide better fracture risk information. So you tiny.
I called that the Holy Grail, right? So that really is sure. We wish we had that. Is that feasible? I think that's aspirational at this point. The slide that I showed you that showed the localization of chest X-ray, CT, and MR was actually from our algorithm. I'll point that out. So there is maybe some hope, but I'm the first to say that that's far from proof that this is an algorithm that will work across all modalities. So yes, great thought, aspirational, but I think in the it's going to take a lot of work to convince me that we can have a truly generalized approach to this.
Okay, so thank you. So we have like besides the great thanks from Gada, from friends from Lebanon. Hi, Gada. Neil, any specific technique to do TBS and femur or humerus?
Yeah, Gada, reach out to me by email and we can discuss that offline. Yes.
So just to, this is a special algorithm to use on with the software, some few other things to be done, but yeah. So we have here from Christopher White, latter is spine X-ray and VFA have already localized the spine. Thoracic and abdominal CT have not. Each site needs to improve its own site performance. It's not plug and play yet. How much longer does it take the machine to learn and then to perform, meaning a clinician time, computing power required to do this and routine, regular routine, and so on. So Bill, it's for you.
Yeah, I'm not sure I understand all aspects of the question, but you're right. It's certainly not plug and play. All of our analysis is done offline. Now, the Zebra Vision approach is an interesting model because what they do is they get access to the PACS, and through an anonymized way of sharing the data, they will actually look at the examinations overnight, so the CT scans, and so the positive cases are flagged, and so it's available not in real time, but in a reasonable time to be able to be acted on. Uh, just to point out that the training part of these processes are typically laborious and can take hours or days. But once you've got a trained algorithm to actually apply it to a data set, especially a small data set like a chest X-ray or VFA, is very rapid, almost instantaneous. So if you have that trained methodology and it's integrated into PACS, which is a couple of big ifs, then it is very rapid in real time.
Yeah, on top of that, I mean, it's very lot of companies are working already on the localized CNN network from box you can plug on your computer, so that you don't have to go on a cloud and just have your data outside, which I know a lot of hospitals are still reluctant to share the data in the cloud and have the return. And so there is major progress being done on localized CNN that you've been learning and reinforced learning at your computer or the RIS system or the PAC systems that could speed up the time and become almost instant. Whether or not you can use the cloud then to share the report, that's another story. But for the calculation itself, time is coming where it'll be much faster. So we have here good questions and congratulations from Klaas. So hi Klaas from Hamburg. Here asking, you alluded the risk of overfeeding, which quite often even happen with 10 to 20 variable in classical multivariate modeling. So with zillion of parameters, that'd be even further and so on. So I'll let you read the paragraph in front of you. So can you comment on that and what else can be do to overcome the risk other than just adding more and more and more data always and always, like escaping toward more data things?
Well, I think there's no substitute for more data. I'll tell you. But I think Klaus's point is that when you work within the same data set, you tend to reinforce and find the same biases that's intrinsic to the data set. So no matter how you do your split data split, you're always working within the same framework. And so the solution, I think, is to go outside, to be external. I think that we're basically looking at models that the genetics people came up with 20 years ago, when people used to do small single cohort analyses of genetics and report the results, and somebody else would try to validate it and they would fall apart. We now know that for GWAS studies, you have to have huge numbers, diverse populations, and have a separate replication data set. I think that this is where the AI techniques really need to develop, and so we're looking at outside data sets, so the data sets that haven't been trained on with our models. So that we can show that in fact this is portable to other settings, because without that, I think you'll have that same situation as the zebra vision versus the Australian validation. Yeah, it looked good in one setting, but it was good but not great in the next setting. So I think that more data, but not at the same time, as much diversity as possible is going to be key to building confidence in this.
Right, thank you. Any data on how long to use denosumab before recommending patient undergoes spine surgery? I know there is some data on teriparatide using for 3 months prior to surgery. And by the way,
I'm unaware of data with DMAB and outcomes prior to spine surgery. There is a publication out there that my AI brain is not working with right now, that documents that DMAB after arthroplasty prevents the periprosthetic loss. Anecdotally, when we've been able to get anabolics, teriparatide, abaloparatide, approved for our patients prior to these big spine operations, that makes common sense to me. And there are data, as the questionnaire alluded to, that 3 months or 6 months may be good. you can light up the bone on histomorphometry with 1 month of teriparatide or 2 months of Romo. You know, as I mentioned, this is opinion-based. We need data.
Thank you very much. I think we come to the end of the questions, and we exceed by 15 minutes. I want to thank you very much, all two speakers. It was really great, very enlightening, and also want to thank Medimat to make that possible, especially Soumya Gore and Shelley Horn, based in India and in United States, so like a different time zone, like morning and late at night already. So thank you very much to make that possible. Thank you for your contribution. Thank you for listening, and for having stayed till the end. And I just wishing you a good day or good evening or good night, depending where you are.